Thank you, everyone. It is now 1 p.m. Eastern Standard Time, and we will reconvene the meeting to begin the next session. We will start with Dr. Megan Wallace, who will be discussing the grade assessment on the Moderna COVID-19 vaccine. Dr. Wallace?
Thank you. Good afternoon. Next slide. The policy question under consideration is, should vaccination with Moderna COVID-19 vaccine be recommended for persons 18 years of age and older? Next. The components of the Pico question are shown on this slide. The population under consideration is persons ages 18 years and older. The intervention is 2 doses of the Moderna COVID-19 vaccine. The comparison is no vaccine. The workgroup identified the 6 outcomes listed here as the most important for the policy question. Next. The outcomes, importance, and data sources available for evaluation of these outcomes are summarized here. For benefits, 2 critical outcomes were selected: prevention of symptomatic laboratory-confirmed COVID-19 and prevention of hospitalization due to COVID-19. There were 2 important benefits selected: prevention of death due to COVID-19 and prevention of asymptomatic infection. The critical harm identified was serious adverse events overall. Additionally, specific harms that have been identified during real-world use were evaluated. An additional important harm, reactogenicity, was evaluated. For all outcomes, data from RCTs were evaluated. For all benefits, observational studies of vaccine effectiveness were evaluated. For serious adverse events, safety surveillance data were reviewed for specific outcomes. Next. To identify relevant randomized controlled trials, we relied on clinicaltrials.gov as the source. We included phase 1, 2, or 3 trials of Moderna COVID-19 vaccine that fit our Pico question. We sought out additional resources, including obtaining unpublished data from the vaccine manufacturer. To identify relevant vaccine effectiveness studies, we used an ongoing, publicly available systematic review conducted by the International Vaccine Access Center, or IVAC, and the World Health Organization, using studies identified through December 10th. From this database, we selected studies that provided vaccine effectiveness estimates for at least one of the benefits defined in our Pico question. Of note, studies that report on VE against any infection were not included, only studies that specifically evaluated VE against symptomatic or asymptomatic infection. We included only studies that had estimates of VE specifically for the Moderna COVID-19 vaccine and not estimates for mRNA vaccines as a group. We reviewed studies of general population and of special populations as long as they included persons aged at least 18 years. For observational data on vaccine safety, in consultation with VAST, we included data from safety surveillance systems that have been presented to ACIP. Next. This flow diagram shows the evidence retrieval for all records included in our evidence synthesis. 127 records were identified from the IVAC systematic review, and 7 were identified through other sources, including 5 records from clinical trials and 2 CDC safety surveillance systems. 38 full-text articles or other resources were assessed for eligibility, and 33 were included in the evidence synthesis. Next. A total of 26 records of observational studies were identified that met our inclusion criteria and addressed one or more of the Pico outcomes. We conducted a risk of bias assessment using the Newcastle-Ottawa scale, which assigns up to 9 points based on specific criteria related to selection, comparability, and assessment of outcome or ascertainment of exposure. Studies with Newcastle-Ottawa scores less than 7 were considered to have serious study limitations. Next. For each outcome, we assess the body of evidence for suitability for pooling. Given that we are working with a fluid evidence base that includes preprints that have not been peer-reviewed, we excluded estimates with serious limitations from the pooled estimates used for grade. If multiple studies were conducted in the same population, the most representative study was selected. Meta-analyses were conducted using the remaining studies. Initial estimates were evaluated for heterogeneity using I-squared. Sensitivity analyses were conducted to assess the influence of study characteristics. The pooled estimates were developed to summarize the estimates across several studies succinctly for grade and describe the best available real-world data for this policy question at this time. However, we acknowledge that the included studies represent different populations and times, and that the science in this area is developing quickly. For this grade analysis, we did not aim to parse out effects of time since vaccination and circulating variants in the VE studies. Next. The grade evidence type assesses the certainty of estimates from the available data. Initial evidence type is determined by the study design. A body of evidence from randomized controlled trials starts with an initial evidence type of 1, indicating high certainty. A body of evidence from observational studies starts with an evidence type of 3, indicating low certainty. The evidence type can then be downgraded due to risk of bias, inconsistency, indirectness, or imprecision, and other considerations could downgrade or upgrade the evidence type. The final evidence type may range from type 1 or high certainty, which indicates we are very confident the true effect lies close to that of the estimate, to type 4, indicating very low certainty, meaning we have little confidence in the effect estimate. The evidence type is not measuring the quality of individual studies, but how much certainty we have in the quantitative estimates of effect across each outcome. Next. Now I will review evidence of benefits. For each outcome, I will first review the data from randomized trials, then review the data from observational studies, and then provide the grade assessment for both. Next. For the critical outcome of symptomatic COVID-19, one randomized study provided data. This was the Moderna Phase 3 RCT, which was conducted in the United States and enrolled over 30,000 participants. The data were published and additional data were obtained directly from the sponsor. We used data through the unblinding date with a data cutoff date of May 4th, 2021. Unblinded safety follow-up continues in trial participants. To consistently apply grade in a rapidly evolving pandemic, we considered the data for benefits in the context of the pandemic during the study time. Next. Using the available efficacy population for all persons ages 18 years and older, there were 55 cases among 14,287 persons in the vaccine arm, and 744 cases among 14,164 persons in the placebo arm, which resulted in a vaccine efficacy estimate of 92.7% and a 95% confidence interval of 90.4% to 94.4%. This is the primary outcome of the study and the outcome used for grade. Next. Vaccine efficacy was also over 90% in a number of key subgroups, including those ages 65 and older, 75 and older, those at risk due to the presence of a comorbidity, those ages 65 years and older and at risk, and those with evidence of prior infection. Next. This table shows vaccine efficacy by timing. VE remained above 90% through unblinding. Next. Now moving on to the observational studies for symptomatic lab-confirmed COVID-19. This slide shows a brief summary of the 14 VE studies reviewed that evaluated this outcome. The most common study design was test-negative design, followed by retrospective and prospective cohort studies. Study locations were predominantly in North America. The preprint studies captured a more recent time period than the peer-reviewed studies. Among these 14 studies, 11 were included in the final pooled analysis for this outcome. Next. This forest plot shows the VE estimates from the 11 studies that were pooled. The pooled VE estimate from observational studies for the outcome of symptomatic laboratory-confirmed COVID-19 was 89.2%. Next. For the grade assessment for the outcome of symptomatic lab-confirmed COVID-19, we evaluated data from one randomized control trial for which the evidence type started at 1. The relative risk of 0.07 and tight 95% confidence interval strongly favored vaccination, and there were no serious concerns in the certainty estimate. The final evidence type was type 1, or high certainty, for this critical outcome. We evaluated 11 observational studies for this outcome. Recall that the evidence type starts at 3 or low for observational studies. The relative risk of 0.11 strongly favored vaccination, with a 95% confidence interval of 0.06 to 0.18. There were no serious concerns in the certainty assessment, and certainty increased due to strong association. For the observational studies, the final certainty was type 2 or moderate. Next. The second outcome for consideration was hospitalization for COVID-19. The protocol included a definition of severe COVID-19 with criteria shown on the slide, but this did not necessarily require hospitalization. We have obtained data on hospitalization due to COVID-19 from the sponsor as an ad hoc analysis. Next. This slide shows the two VE estimates from the randomized control trial. The first row shows the vaccine efficacy against severe COVID-19, a secondary endpoint defined in the phase 3 protocol, which was 98.1%. The second row shows VE against severe COVID-19 requiring hospitalization, which was our Pico outcome and the outcome used for grade. The VE estimate was 95.9%. Next. The 19 observational studies that evaluated VE against hospitalization due to COVID-19 are summarized here. The most common study design was test-negative design, and study locations were predominantly in North America. Among the 19 observational studies, which provided 20 VE estimates, 14 studies providing 15 estimates were included in the final pooled analysis. Next. For the outcome of hospitalization due to COVID-19, this forest plot shows the 15 VE estimates from the observational studies included in the meta-analysis. The pooled VE estimate from these studies was 94.8%. Next. For the grade assessment for this outcome, hospitalization due to COVID-19, we evaluated one RCT for which the evidence type started at 1. The relative risk of 0.04 strongly favored vaccination, but there were serious concerns of imprecision due to the small number of events observed from a single RCT. The final certainty estimate for hospitalization for COVID-19 based on RCT data was type 2 or moderate certainty. We evaluated 14 observational studies which provided 15 VE estimates for this outcome for a pooled relative risk of 0.05. There were no serious concerns in certainty assessment, and the certainty was increased due to a strong association. The final certainty estimate based on the observational data was type 2 or moderate. Next. The next outcome was death due to COVID-19. This was a secondary efficacy endpoint in the trial protocol, defined as any participant who died during the study with a cause directly attributed to a complication of COVID-19. Next. There were a total of 3 deaths due to COVID-19 among trial participants, all among placebo recipients. The available data indicates a VE of 100%. Next. 5 observational studies provided VE estimates for the outcome of death due to COVID-19. These were all cohort studies with study locations predominantly in North America. Next. This forest plot shows the 5 VE estimates from observational studies for the outcome of death due to COVID-19. The pooled VE estimate from these studies was 93.8%. Next. For the grade assessment for the outcome of death due to COVID-19, we evaluated one RCT. The relative risk of 0.17 favored vaccination, but the very wide 95% confidence interval did not rule out harms, leading to very serious concern for imprecision due to the small number of events observed in a single RCT. The final evidence type was type 3 or low certainty. The body of evidence from observational studies started with an evidence type of 3. There were no serious concerns in the certainty assessment. In light of the strong association, the certainty was raised 1 level to type 2 or moderate certainty. Next. The next outcome of interest was asymptomatic SARS-CoV-2 infection, which was a secondary endpoint in the phase 3 RCT. Asymptomatic SARS-CoV-2 infection was defined as having a negative SARS-CoV-2 status and both negative RT-PCR and negative binding antibody levels against SARS-CoV-2 at baseline prior to dose 1, and positive RT-PCR at the participant decision visit or seroconversion due to infection assessed by binding antibody levels against SARS-CoV-2 at day 57, 28 days after dose 2, and an absence of COVID-19 symptoms, including both symptoms for the primary endpoint of COVID-19 and the CDC definition of COVID-19. Next. Using the per-protocol population for all persons ages 18 years and older, the VE for asymptomatic infection was 57.4, with a confidence interval from 50.1 to 63.6. Next. The 3 observational studies that examined VE against asymptomatic SARS-CoV-2 infection and met our inclusion criteria are summarized here. All were peer-reviewed and 2 were test-negative study design. Our most recent data are from September. Next. The VE estimates from the 3 studies are shown here. Note that there is substantial heterogeneity in the effect estimates. The pooled VE from these studies was 69.8%. Next. In the grade assessment of the outcome of asymptomatic infection, one RCT provided data. The relative risk of 0.43 favored vaccination, and there were no serious concerns in the certainty assessment. The final evidence type was 1 or high certainty. We evaluated 3 observational studies that had a pooled relative risk of 0.3. There was serious concern for inconsistency because the magnitude of relative risk from the 3 studies in the body of evidence varied widely. The final evidence type was type 4, or very low certainty. Next, I'll share data on grade for harms. Next. 4 randomized studies provided data on harms. These included the phase 3 trial, the phase 2 trial, and 2 published articles on the phase 1 trials, which did not have an unvaccinated comparator. Next. The phase 3 study included data on persons ages 18 years and older in the United States. The data evaluated had a final analysis cutoff date of May 4th and consisted of roughly 30,000 participants. Next. The phase 2 dose confirmation RCT enrolled healthy adults ages 18 years and older in the United States. We evaluated data on the 200 participants that received the 100 microgram dose and the 200 participants that received placebo. The primary outcomes for the phase 2 trial were safety, including reactogenicity and serious adverse events. Next. Here are the raw data on the critical outcome serious adverse events from the 2 randomized studies. From the phase 2 trial, there were no serious adverse events in either treatment group. In the phase 3 trial, SAEs were balanced across treatment groups, with 1.8% of vaccine recipients and 1.9% of placebo recipients reporting an SAE. 12 participants reported 15 SAEs, which were deemed by blinded investigators to be related to vaccination. Next. We also assess specific serious adverse events that have been identified in safety surveillance during the period of the emergency use authorization, which have previously been described to ACIP. A rapid cycle analysis from Vaccine Safety Data Link evaluated chart-reviewed cases of myocarditis occurring among persons aged 18 to 39 years following dose 2. As shown in this table, based on events occurring in a 7-day risk interval after vaccination versus a comparison interval in vaccinated individuals, the adjusted rate ratio was 18.75. Next. Data from the National Vaccine Adverse Event Reporting System, or VAERS, showed an elevated ratio of observed to expected chart-confirmed myocarditis cases in the 7-day interval following vaccination among females ages 18 to 29 years and among males ages 18 to 49 years, with higher observed to expected ratios in males than females. Although VAERS data are subject to the limitations of a passive surveillance system, the elevated risk of myocarditis following Moderna vaccination is consistent with that observed in VSD. Next. Regarding anaphylaxis, a rapid cycle analysis of data from VSD evaluated chart-reviewed cases of anaphylaxis among all vaccinated persons aged 18 years and older. Based on events occurring in a 0 to 1 day risk interval after vaccination, the estimated incidence of confirmed anaphylaxis was 5.1 per million doses. Next. The grade assessment for serious adverse events was based on 2 RCTs. The pooled relative risk indicated a balance of serious adverse events between vaccinated and placebo groups, with a relative risk of 0.92 and a 95% confidence interval of 0.78 to 1.08. The certainty assessment was reduced 1 point due to serious concern of imprecision because the confidence interval indicates that both reduced and increased risk of serious adverse events are possible. The final evidence type was type 2, or moderate certainty. The observational data concerning the specific serious adverse events of myocarditis and anaphylaxis included the description of the quantitative data shown on previous slides. We started with type 3 data from observational surveillance systems and did not decrease or increase the certainty. The final certainty was type 3, or low certainty. Next. For the outcome of severe reactogenicity, the phase 2 and 3 RCT solicited events through electronic diaries for the 7 days following each dose. Both randomized studies used the same events and grading scales shown here. The local reactions solicited were injection site pain, redness, swelling, and axillary swelling and tenderness. The systemic events listed were fever, nausea and vomiting, headache, fatigue, chills, muscle pain, and joint pain. Next. In the phase 2 study, grade 3 or 4 reactions or systemic events were reported in 16% of persons in the vaccine arm and 3% of persons in the placebo arm. In the phase 3 study, grade 3 or 4 reactions were reported by 22.6% of persons in the vaccine arm and 4.5% of persons in the placebo arm. Next. Pooling the data from these two trials, the estimated relative risk for any grade 3 or 4 event was 5.03, with a 95% confidence interval from 4.65 to 5.45. There were no serious concerns in the certainty assessment. The final evidence type was type 1, or high certainty. Next. This table summarizes our grade assessment for the Moderna COVID-19 vaccine. In terms of benefits, the available data indicate that the vaccine is effective for preventing symptomatic COVID-19 with high evidence certainty. For hospitalization and death, the available evidence favors the intervention and certainty was moderate. For asymptomatic SARS-CoV-2 infection, the available data favors the intervention with high evidence certainty. In terms of harms, in the RCTs, SAEs were balanced between vaccine and placebo arms. In post-authorization safety monitoring, myocarditis and anaphylaxis were rare, but more common following vaccination. Serious adverse events had moderate evidence certainty. In terms of reactogenicity, severe reactions were more common in vaccinated persons. In 21.3% of vaccine recipients versus 4.5% of placebo recipients reported grade 3 or 4 reactions. The evidence type for reactogenicity was high. Next. There are important limitations that should be acknowledged. In this rapidly evolving pandemic, the available body of evidence often does not represent the most recent epidemiology, including the impact of a new dominant variant on VE. The evidence available for inclusion in this grade does not capture the impact of the Omicron variant on vaccine effectiveness. The VE estimates presented represent the best estimates within the context of the pandemic during the time of the study, but may not be representative of VE in different phases of the pandemic or with different circulating variants. The evidence available for inclusion in this grade is predominantly from the time periods in which Alpha and Delta were the dominant circulating variants. Next. In conclusion, the grade evaluation focuses on recommendations following licensure of the Moderna COVID-19 vaccine that has been in use for a year under an emergency use authorization. Evidence for benefits are supported by a body of evidence comprised of one large phase 3 randomized control trial and numerous observational studies conducted worldwide. The RCT evidence demonstrated efficacy for all beneficial outcomes, including the 2 critical outcomes, symptomatic disease and hospitalization. Efficacy data were further supported by a body of evidence from observational studies. Regarding harms, grade 3 reactions were more common in vaccine than placebo recipients. RCT evidence showed that serious adverse events occurred at a similar frequency in vaccine and placebo groups overall. However, 2 specific rare but serious adverse events have been associated with vaccination, as identified through safety surveillance systems. Next. In closing, I would like to acknowledge the team that contributed to grade. Each of the people listed on this slide played a vital role in synthesizing the information that was presented today. Next. Thank you.
Thank you for your presentation. This presentation is now open for questions. I don't see any hands raised from the members. Are there any questions from our liaison members? Dr. Paling, thank you.
Okay, so Dr. Wallace, thank you for a beautiful presentation. I actually don't have any questions. I just wanted to say a very special thanks to the tremendous amount of work that was done in pulling this and how reassuring it is that the randomized control trials and the observational studies are showing the same pattern. So I just want to say a thank you to you and your team.
Thank you. And it was certainly a team effort. Thanks.
And thanks, Dr. Wallace. I think that goes for all of us, with Dr. Paling's words. Dr. Daly.
Yeah, I was going to say something very, very similar, just that, you know, these data are all very important and you presented in such a clear and consistent way. And I'm sitting at my desk in Denver, but I would give you a standing ovation if I could. So again, thanks to you and your team for this, and we really appreciate it.
Perfect. I think with that, why don't we move on to the next presentation by Dr. Sarah Oliver. And just know that you can come back, and I know Dr. Wallace will probably still be in the room after Dr. Oliver's done. So we'll continue on with the EtR framework from the Moderna COVID-19 vaccine. Dr. Oliver.
Thank you very much. I can tell you we clapped for Dr. Wallace in the room. So, all right. Good afternoon. Next slide. So as a reminder, this is the policy question that we'll vote on later today. Should vaccination with the Moderna COVID-19 vaccine be recommended for persons 18 years of age and over? We presented this previously with the Pfizer BLA, but as a reminder, with the FDA authorization of an EUA, ACIP has made interim recommendations. Then, as the vaccine receives full FDA approval under the BLA, ACIP reviews the totality of the data available and votes to make a standard recommendation. Next slide. Then another reminder, for regulatory action, grade, the EtR Framework, and the ACIP vote, we consider the Moderna COVID-19 vaccine compared to no vaccine. Next slide. Then this afternoon, we'll have additional questions for discussion focused on implementation, myocarditis, and intervals. During those discussions, we'll discuss data for both the Moderna COVID-19 vaccine and the Pfizer vaccine. Next slide. This is the Pico question we're using for the EtR framework. Next slide. And again, as a reminder, the EtR framework with each domain listed and the questions that will be addressed. Next slide. So first for the public health problem. Next slide. So this slide shows the trends in daily number of COVID-19 cases in the US. To date, there have been over 75 million cases reported to CDC. We recently experienced a substantial surge that peaked mid-January with a 7-day moving average of over 800,000 cases per day. Since mid-January, cases have been declining, and the current 7-day moving average is now just over 400,000 cases. Next slide. Next, we'll take a look at trends in daily number of COVID-19 deaths in the US. As of February 1st, there have been over 888,000 deaths due to COVID-19 reported in the US. Next slide. Then this slide illustrates the rates of COVID-19 cases by vaccination status. Unvaccinated people in all age groups had higher case rates than fully vaccinated people in the same age groups. Notably, in November, unvaccinated adults aged 18 years and over had 4 times greater risk of testing positive for COVID compared to fully vaccinated adults. Next slide. And then importantly, unvaccinated adults, the vaccines continue to provide substantial protection against severe disease and death. So unvaccinated adults, 18 years of age and over, had a 15 times greater risk of dying from COVID compared to fully vaccinated adults. Next slide. Then furthermore, people who were fully vaccinated and had received an additional or booster dose had an even further lower risk of testing positive and dying from COVID compared to people who were unvaccinated. But I'll highlight here that the largest gap is between those who are unvaccinated and those who are fully vaccinated. Next slide. This slide shows the weekly trends in COVID-associated hospitalization rates in the US. There's a reporting delay in recent weeks, but you can see that across all ages, hospitalizations have increased in recent weeks. Next slide. While COVID hospitalization rates have been increasing, it's important to evaluate the hospitalization rates by vaccination status. So this slide shows the rates of COVID-associated hospitalization by vaccination status in adults 18 to 49 years between January and December of 2021. In December, compared to fully vaccinated adults 18 to 49 years, the monthly rates of COVID-associated hospitalizations were 12 times higher in unvaccinated adults 18 to 49 years. Next slide. Additionally, compared to fully vaccinated adults 50 to 64 years of age, the monthly rates of COVID-associated hospitalizations were 18 times higher in unvaccinated adults in the same age range. Next slide. And then finally, in those adults 65 years of age and over, COVID-associated hospitalizations were 18 times higher in unvaccinated adults 65 and over compared to fully vaccinated adults in that same age range. Next slide. We know that those hospitalizations can take a toll on the healthcare system. So this slide shows ICU utilization by state. And as of February 3rd, over half of states were at 80% ICU capacity or greater. Next slide. I think we're all familiar with this at this point, but this graph shows that Omicron is now the dominant circulating SARS-CoV-2 variant in the United States, shown here in purple. Next slide. So next we'll take a look at the daily count of total doses administered and reported to CDC by date administered in the United States. So as of February 1st, the 7-day moving average for doses administered was over 464,000 per day. Next slide. But we do know that approximately 25% of people aged 18 and over are not fully vaccinated. Next slide. So now taking a look at COVID vaccine administration by vaccine type, over 540 million COVID vaccines have been administered in the US, and over 204 million of those were the Moderna COVID-19 vaccine. Next slide. Then we know that over 212 million people are fully vaccinated in the US, and over 74 million of those received the Moderna 2-dose series. Next slide. Then this slide shows the percent of COVID vaccination coverage by age and date administered. The highest coverage is among the oldest, with 95% of those 65 and over having received at least one dose. The lowest coverage is 75% with at least one dose among those 18 to 24 years of age. Next slide. Then as we focus on those fully vaccinated with Moderna by week and age group, again, we've seen similar patterns where more doses were administered earlier in the rollout and older adults received their vaccines earlier. Next slide. Then we know that those fully vaccinated varies by geographic location as well, as highlighted here in a map of the United States. Next slide. So in summary for the public health problem, the Omicron variant is the dominant circulating variant in the United States. In January, COVID-19 cases, hospitalizations, and deaths have increased, although cases have been declining in recent weeks. In November of 2021, unvaccinated adults 18 years of age and over had 4 times the risk of testing positive and 15 times the risk of dying from COVID compared to fully vaccinated adults. But we know that increasing cases are taxing healthcare resources, with many states facing ICU bed shortages again. We do know that over 200 million people are fully vaccinated in the US. However, vaccination coverage varies by age and geography. Next slide. So the workgroup agreed that COVID-19 disease among adults continues to be of public health importance. Next slide. So moving to benefits and harms. Next slide. We'll first very briefly review GRADE, which was excellently described recently. Next slide. As we just heard, for benefits, the clinical trial demonstrated efficacy against symptomatic labbed confirmed COVID, which was further supported by observational data. Overall efficacy was 92.7% with high certainty. The clinical trial also demonstrated efficacy against hospitalization, again further supported by observational data. The overall efficacy was 95.9% with moderate certainty of evidence. Deaths were uncommon in the clinical trial. However, observational data again demonstrated effectiveness against death due to COVID-19. The pooled vaccine effectiveness was 93.8% with moderate certainty of evidence. And finally, the clinical trial demonstrated efficacy against asymptomatic SARS-CoV-2 infection. Overall efficacy was 57.4% with high certainty. Next slide. Then in terms of harms, serious adverse events were reported in a similar proportion among recipients of vaccine and placebo. 2 specific rare serious adverse events have been associated with vaccination through safety surveillance. There was moderate certainty of evidence for these SAEs. Serious reactions were more common in vaccine recipients, and any grade 3 or more reaction was reported by 21% of vaccinated versus 4.5% of placebo groups, and the reactogenicity had a high evidence certainty. Next slide. In conclusion, the GRADE evaluation focused on recommendations following licensure of the Moderna COVID vaccine that has been used for a year under the emergency use authorization. Evidence for benefits are supported by a body of evidence comprising one large phase 3 randomized controlled trial and numerous observational studies conducted worldwide. The RCT evidence demonstrated efficacy for beneficial outcomes, including the 2 critical outcomes, symptomatic disease and hospitalization. Efficacy data were further supported by the body of evidence from observational studies. Regarding harm, grade 3 events were more common in vaccine than placebo recipients. But overall, RCT evidence showed that serious adverse events occurred at a similar frequency in vaccine and placebo groups overall. However, these 2 specific but rare adverse events have been associated with vaccination as identified through our safety surveillance systems. Next slide. So now we'll move to discuss the potential risk of myocarditis and the potential benefit and harm balance. Next slide. In vaccine safety surveillance, VAERS has demonstrated reporting rates of myocarditis greater than the background rates for males in the age groups 18 to 49 years and females after dose 2 in the 18 to 29 years. But we know that at least 90 days after myocarditis diagnosis, most patients reported no impact on their quality of life, and most did not report missing school or work. And most healthcare providers indicated that the patient was probably or fully recovered. Next slide. Now, as we think through the benefit-risk balance for the Moderna COVID vaccine in adults 18 to 39 years. Next slide. For assessment of this benefit-risk balance, the benefits were calculated per 1 million people who are fully vaccinated. Then I want to highlight for this, we focused on the age group of 18 to 39 years, which was selected because this age group has the highest rates of myocarditis and lowest hospitalization rates among adults, and would therefore have the closest benefit-risk margin. We use age and sex-specific hospitalization rates from COVIDnet and pooled VE estimates from 2 platforms. The benefits were calculated over a 150-day or 5-month period. Harms were calculated as per 1 million persons who were fully vaccinated, and the vaccine-specific myocarditis rates from the vaccine safety data link were used. Next slide. So then these are the vaccine-specific estimates of effectiveness against COVID hospitalization from both the IV network and Vision that were pooled to create a final VE estimate of 92%, which is the VE estimate used in the model. Next slide. This slide shows rates of myocarditis following the Moderna COVID-19 vaccine per million second doses administered among persons aged 18 to 39 years from VSD. Myocarditis was most common in males who had a rate of 67.5 myocarditis cases per million second doses in that 7-day risk period. Next slide. On this slide, we see the COVID-associated hospitalizations prevented by the Moderna vaccine compared with myocarditis cases expected, results presented per million fully vaccinated persons, 18 to 39 years. On the left side of the figure, COVID hospitalizations prevented are represented by dark red bars, and on the right side, we see myocarditis cases expected by the light red. As you can see, over the course of 5 months, we would expect many more COVID hospitalizations prevented than myocarditis cases expected. Next slide. Then on this slide, you see the same structure, but with results presented per million fully vaccinated males aged 18 to 39. Again, as before, COVID hospitalizations on the left and myocarditis cases on the right. As you can see, again, over the course of 5 months, in males 18 to 39 years who have the highest rates of myocarditis overall, we would still expect many more COVID hospitalizations to be prevented than myocarditis cases expected. Next slide. For the benefit-risk balance, there are a few limitations that should be noted. We consider direct benefits and risk over the 150-day period, comparing vaccine to no vaccine. The VE assumptions used in the model do not yet include Omicron-specific VE estimates, and we assume static hospitalization rate over 5 months, and the benefit-risk profile would change as hospitalization rates change. And finally, the model does not account for booster doses or prior infection. Next slide. So to summarize the benefits and harms, the clinical trial and observational studies demonstrated the Moderna vaccine is effective in the prevention of COVID in persons 18 years of age and over. The risk of myocarditis or pericarditis is noted after the mRNA vaccines, and the highest risk was again seen after the second doses in younger males. However, the benefits for the Moderna COVID-19 vaccine far outweigh any possible vaccine-associated risk. Next slide. So in summary, the workgroup felt the desirable anticipated effects were large. Next slide. Undesirable anticipated effects were small. Next slide. And that the balance favored the intervention. Next slide. Now for values. Next slide. We've seen this figure previously showing the overall proportion reporting positive vaccine intentions by month of data collection, with bubbles proportional to the survey size. The surveys were conducted among adults asking about their intent to receive the COVID vaccine, and the overall intent has consistently increased since 2020 when the vaccines were authorized. Next slide. This slide shows vaccination status and intent among adults 18 years of age and over in the US from this survey. Almost 85% of adults reported that they are vaccinated or definitely will get vaccinated. 4% reported they probably would get vaccinated or unsure, and 10% reported they would probably or definitely not get vaccinated. Next slide. Then a survey of the American general population was conducted on individuals 18 and over between January 7th and 10th of 2022. Unvaccinated survey respondents were asked, does the discovery of the Omicron variant make you more or less likely to get the COVID vaccine? You can see that the majority of respondents expressed that it makes no difference, whereas a smaller proportion said that they would be less or more likely to receive the vaccine. Next slide. Then when those unvaccinated adults were asked what, if anything, would convince those who remain unvaccinated to receive a COVID vaccine, half of unvaccinated adults said that nothing would convince them to get a COVID vaccine. 1 in 7 offered that more research or transparency would convince them, and fewer said that they would get it if it was required for work or mandatory, if they received a large monetary incentive, if their doctor recommended it, or if the vaccine prevented 100% of infections. Next slide. We do know that initial data indicated following FDA's full approval of the Pfizer vaccine in the US, there was a slight uptick in the average number of Americans getting their first COVID vaccine dose, although not a rapid surge in vaccinations in the days immediately following approval. Full approval may have been enough to convince some to finally get immunized. Next slide. Then another ongoing survey designed by CDC and the University of Iowa to assess vaccine intent of unvaccinated Americans. In response to this FDA BLA for the Moderna vaccine, data was collected from January 27th through January 31st, 2022, with a current sample size of around 500 respondents. Next slide. When asked about reasons surrounding vaccine hesitancy, concerns about vaccine side effects, or general mistrust of COVID vaccines were the top reasons for remaining unvaccinated. Next slide. Then during the data collection period, 29% of the unvaccinated respondents said that they thought the Moderna COVID vaccine already had full approval from the FDA. Next slide. In relation to vaccine intentions in response to the Moderna BLA, 5% of unvaccinated respondents said that they would get a vaccine as soon as they could if the Moderna vaccine received full approval from the FDA. Next slide. An additional 20% of unvaccinated respondents said they would continue to wait and see if COVID vaccines were safe. Next slide. 50% said they would definitely not get vaccinated or would only do so if it was required. Next slide. 11% of unvaccinated respondents said that they would wait a few more weeks to get a COVID vaccine after the Moderna vaccine received full approval, but were open or unsure about getting that vaccine. Next slide. And an additional 11% of unvaccinated said that they would wait more than a year to get a COVID vaccine after the Moderna vaccine received full approval. Next slide. So overall, the workgroup felt that the overall population felt the desirable effects were large relative to undesirable effects. Next slide. However, there was probably important uncertainty or variability in how people value the outcome. Next slide. So moving to acceptability. Next slide. As of February 2nd, over 200 million doses of the Moderna vaccine have already been administered and implemented in a wide variety of settings, including state and local health departments, mass vaccination clinics, long-term care facilities, and retail pharmacies. Next slide. Vaccination with the Moderna COVID vaccine was already highly acceptable to stakeholders under FDA's emergency use authorization and ACIP interim recommendations. Vaccination may be more acceptable under full FDA approval and standard ACIP recommendations. Next slide. So the workgroup felt that the Moderna vaccine is acceptable to key stakeholders. Next slide. Moving to feasibility. Next slide. So these are the barriers, possible barriers to implementation that have been mentioned in previous ETRs. Next slide. The Moderna vaccine will be the second vaccine with the BLA. The BLA has only been issued for some indications, which could add complexity. The BLA is issued for the primary series in those 18 years of age and over, while the EUA recommendations remain for the additional dose and booster dose recommendations. In addition, recommendations made under EUI, which can only be made for vaccines with a BLA, will now be extended to include the Moderna vaccine. Next slide. There have been a variety of updates and improvements to the vaccine storage and handling requirements since the initial EUA. Now the vaccine can be stored frozen and refrigerated for up to 30 days prior to the first use. Next slide. And as throughout the pandemic, all COVID vaccines are provided to the US free of charge. However, health systems or health departments can incur costs for vaccine implementations, clinics, and outreach. And we know that financial hardships may arise if vaccine recipients need to take time off of work or could experience post-vaccination reactogenicity that would keep them from work. Next slide. We aren't anticipating any supply barriers. Vaccine supply in the US is sufficient for implementation of the intervention. As of February 2nd, over 200 million doses have already been administered in the US, which demonstrates that the vaccine is feasible to implement broadly. Next slide. And the workgroup said that the vaccine is feasible to implement. Next slide. Moving to resource use. Next slide. This graph illustrates one analysis with the estimated cost of preventable COVID hospitalizations among unvaccinated adults in the US. From June through November of 2021, preventable COVID hospitalizations among unvaccinated adults were estimated to cost over $13 billion. Next slide. Vaccine doses purchased with US taxpayer funds will be given to people living in the US at no cost. And several published modeling studies have found that COVID vaccines are likely to be of reasonable economic value and may also be cost-saving under many circumstances. Next slide. So while not a primary driver of decision-making in the pandemic, the workgroup still felt that the Moderna vaccine was a reasonable and efficient allocation of resources. Next slide. Finally, for equity, next slide. This slide shows the cumulative COVID-19 associated hospitalizations in the US by race and ethnicity for March 7th of 2020 through March 22nd of 2022. As illustrated, American Indian and Alaskan Native, Black, and Hispanic populations have consistently had the highest rates of COVID-19 associated hospitalizations in the US. Next slide. Now we'll take a look at percentage of people 18 years of age and over who've received at least one dose of the COVID vaccine by race and ethnicity over time. As illustrated, American Indian and Alaskan Native populations have consistently had the highest percentage of those receiving at least one dose of COVID vaccine. Next slide. This figure shows similar with the percentage of COVID of people 18 years of age and over who've received at least one dose by race and ethnicity over time. Next slide. Now, taking a look at COVID-19 vaccination coverage by geography, only 20% of U.S. counties report 70% or more of the population 18 years of age and over that are fully vaccinated. Next slide. We know that vaccine uptake lags in adults living in rural and suburban areas compared to urban areas. As of November of 2021, 8 in 10 urban residents say that they've received at least one dose of a COVID vaccine, compared to 7 in 10 suburban adults and 67% of rural adults. 1 in 5 of those living in rural areas and 1 in 6 of those living in suburban areas say they will definitely not get a COVID vaccine, which is at least twice what urban residents say. Next slide. Then in an MMWR that was published just this week, COVID vaccination coverage was assessed among LGBT adults 18 years in age and older. By sexual orientation, gay or lesbian adults reported higher vaccination coverage overall than heterosexual adults, and there weren't significant differences in vaccination coverage among persons based on gender identity. Vaccination coverage was lowest among non-Hispanic, Black, LGBT persons across all categories of sexual orientation and gender identity. Next slide. So there's considerable variability in the interpretation of the equity domain, but overall, the workgroup felt that the approval of the Moderna vaccine would probably have no impact on health equity. Next slide. So in summary, next slide. This is the summary of the workgroup judgments for each of the EtR domains. Next slide. So I know this slide looks complex, but just highlighting that for both of the primary series and additional booster doses, and for all 3 COVID vaccines used in the US, there are EUAs in place. 2 of those EUAs, the primary series for Pfizer in those 16 and over, and the primary series for Moderna in those 18 and over, have full FDA approval with the BLA. The authorization and any vote by ACIP today won't override any existing recommendations for the EUAs. And ACIP will continue to review data as additional vaccines and indications move from EUA to BLA. Next slide. Overall, COVID-19 vaccines have been a critical tool in this pandemic, preventing millions of COVID-19 associated hospitalizations and death. To date, hundreds of millions of doses of the Moderna COVID-19 vaccine have been given, with over a year of incredibly closely monitored real-world safety and effectiveness data. Vaccinating the unvaccinated with a primary series continues to be important, with additional protection from all recommended COVID-19 vaccine doses important over the course of an evolving pandemic. Next slide. So this is the summary of the workgroup interpretations with a balance of consequences. We've shown this before, but where undesirable consequences outweigh desirable on the left and desirable consequences outweighing undesirable on the right. Next slide. The workgroup felt that the desirable consequences clearly outweigh undesirable consequences in most settings. Next slide. Then looking for the type of recommendation proposed by the workgroup. Next slide. The workgroup recommended the intervention. Next slide. Again, there is a small but mighty team that puts all of this together, and so none of this would happen without them. Want to thank them. Next slide. Yeah, okay. Happy to take any questions and turn it over to you, Dr. Lee.
Thank you, Dr. Oliver, as usual, an excellent presentation and a really wonderful overview of the work of the work group. I want to open this presentation for questions from the committee members. or from our liaison members? Dr. Hahn.
Yeah, thank you. First of all, I agree. Wonderful presentation and wonderful to hear. I wanted to make a comment that really just I came to fully understand in the last week or so, and I just wanted to bring it forward. We continue to get questions about hospitalization case rates, but also particularly hospitalization rates among people partially vaccinated. And we kept saying, no, we consider them unvaccinated because they're unvaccinated, and that's where they show up in the data. And it wasn't until recent conversations with continued queries, let's say, from members of the public, that I realized that the perception, and I would go so far as to say kind of the rumor or the theory, is that partially vaccinated people, if you will, people who've had a single dose, or maybe people who've just gotten their second dose, make up a large percentage of what we're calling unvaccinated people in the hospitals, and that the hospitals are filling up with people who got a dose of the vaccine, and maybe even that somehow gave them COVID, whether it's from the vaccine itself or whether it's from some sort of immunosuppression after the vaccine. I can't say, but I did not grasp that was the concern. But we have gone ahead and started to produce data showing this as a separate group. And I just wanted to bring it up now. I know it's a little bit off the topic of what we're talking about today, but we keep showing these slides, and it keeps striking me every time that we might want to think about showing this group separately. And for example, we were able to demonstrate that our hospitals, that's a very small percentage of people in our hospitals right now that had a single dose or that had recently been vaccinated. So I just wanted to make that comment, and I don't know if there's any response needed, but I just wanted to say that. Thank you.
Thank you, Dr. Hahn. Are there any additional questions or comments? While we're waiting to see if any additional hands will be raised, I just wanted to, comment on the resource allocation issue, which I recognize the mandate of ACIP is really the health of the U.S. population, but also just wanted to highlight that the estimated impact or economic burden doesn't really reflect the true cost of the pandemic in our society. It's not just hospitalizations and the cost of those hospitalizations. It's, the work missed, the businesses closed, wages lost. It's the worsening of the already existing educational disparities in this country, which I think also has long-term economic consequences on this generation of kids directly impacted by the pandemic. I recognize it's nearly impossible for you to capture all of that in our resource sort of assessment. But I do think it's important to acknowledge that in some way, because this goes well beyond the way we typically think about vaccine deliberations at ACIP. Are there any other questions or comments from our committee members or from our liaison members? Dr. Paling.
Dr. Oliver, thank you for a fantastic presentation. It was very clear. I just wanted to get input. Was there much diversity in the opinion of the work group in voting for the recommendation?
Thank you. There absolutely was not. The work group overwhelmingly agreed that they would recommend the intervention, which is the 2-dose Moderna primary series. Thanks.
Thank you. I don't see any additional hands raised at the moment. While we're waiting to see if there's any additional questions, comments, or clarifications, I'm actually going to ask you, Dr. Oliver, to, if you're able to put up, and I believe we're ready for this, put up the wording for a proposed vote. That would be really helpful.
Dr. Lee, do you want me to read it?
Please go ahead.
Okay. So the language for the vote is the Moderna COVID-19 vaccine, BLA approved vaccine called Spikevax, the 2-dose primary series, is recommended for persons 18 years of age and over. This isn't included in the vote language, but we just wanted to make sure that we clarified the ACIP recommendations addressing the EUA uses of the Moderna vaccine will remain in effect. So this only would move the recommendation for the 2-dose primary series from kind of that interim recommendation under EUA to full recommendation. The other EUA votes would remain in effect.
Thank you. Are there any questions, clarifications, or discussion points that people would like to add? Okay, do any of our voting members wish to make a motion? Dr. Paling, I saw your hand raised.
Yes, I would like to make a motion to accept this verbiage. Thank you.
Thank you. So proposal to accept the ACIP vote language on this current slide. Dr. Alt?
I will second the motion.
Thank you, Dr. Paling and Dr. Alt. It's been moved and seconded that we adopt the recommendation language presented by Dr. Oliver and the work group on behalf of the work group. Any additional questions or issues the committee would like to discuss before the vote? Okay, I see people are eager to vote. Since there's no additional hands raised, we will move forward, and I see my ACIP members already turning on their video. Please state your, as a reminder, after you turn on your video, I'm going to ask you to state your name, whether you have a conflict of interest, and then your vote. Give me a moment, sorry. All right, terrific. Today we will start with Dr. Alt.
Alt, no conflicts, yes.
Thank you. Ms. Bata.
Bata, no conflicts, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Just to warn my colleagues, I'm going actually in alphabetical order today. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen.
Gilbert Chen. Let me state that my university has grant funding from the Emergent Biosolutions for development of a Shigella vaccine. I don't perceive this as a true conflict. My vote is yes.
Thank you, Dr. Chen. Dr. Sineas.
Demo Sineas, no conflict, yes.
Thank you. Dr. Daly.
Matt Daly, no conflict, yes.
Thank you. Dr. Cotton.
Emil Cotton, no conflict, yes.
Thank you. Dr. Lair.
Amy Lair, no conflict, yes.
Thank you. Grace Lee, no conflicts, yes. Dr. Paling.
Kathy Paling, no conflict, yes.
Thank you. Dr. Sanchez.
Los Sanchez, no conflict, yes.
Thank you. Dr. Talbot.
If Talbot, no conflicts, yes.
Thank you. I believe we have 13 yeses, 0 nos, and so the motion passes as stated. I'll ask if there's any comments people would like to make on their vote. It's not required, but I just wanted to make sure I offer the opportunity to my colleagues. Dr. Daly.
Yeah, I have to be honest. I still have a sense of wonder at what's been accomplished here, that and a deep sense of gratitude. We now have 2 vaccines against COVID-19 that are fully licensed in the US. And these vaccines were authorized and then licensed along a rapid timeline while still following all the well-established regulatory processes in place before the pandemic. And as I mentioned earlier today, an estimated 1.1 million deaths have been averted through vaccination in the US and countless more globally. And I don't think we can take this for granted. We shouldn't assume that this was an inevitable outcome. To put this in a more personal context, we all have individuals in our lives, parents, grandparents, children, friends, who may have gotten sick or died from COVID who did not because of vaccination. And for that, I'm very grateful. I say all this while still wanting to acknowledge that many have lost their lives to COVID, and we're all still vulnerable, particularly the very young, the very old, the unvaccinated, and those with immunocompromise. So I know we still have a lot of work to do, and we have a lot of challenges ahead of us with respect to the pandemic and the role that vaccines play. But today, I'm just very appreciative of all that's been accomplished. Thank you.
Thank you, Dr. Daly. And we all appreciate your leadership of the COVID vaccines work group, which has been quite busy. Dr. Bell.
Thank you. I wanted to sort of comment on a sort of a corollary to what Dr. Daly just said. The ACIP, one of the things that we value the most is transparency. And one of the things, therefore, that I think we can see from this process today is in a broad context, evaluating risks and benefits using evidence, scientific evidence that's been accumulated over a long period of time now with millions of people vaccinated. We can see the power and the value of vaccination. And so I would just like to say one other thing that we continue to see is that the biggest risk to individuals is not getting vaccinated. So I hope that by this transparent process where we have summarized in a very sort of comprehensive way, looking at the context, the big picture, and then very sort of detailed individual scientific data, the huge value and benefit of getting vaccinated. And I hope that at least for some people who are still thinking about whether they should get vaccinated, that this process and this transparent meeting helps them to do the most important thing that they can do to protect themselves and their family, and that is to get a vaccine.
Thank you for those words, Dr. Bell. Any other comments or statements? I see Dr. Duchin would like to make a comment.
Thank you, Dr. Lee. I would just like to reinforce the importance of the booster dose. I know we've been talking about the primary series here, rightly so, but there are many people in our community and many communities throughout the country who have received that primary series and who haven't yet, who are eligible, but yet have not received the booster dose. And it's critical to understand how necessary that booster dose is to receive the full protection that these vaccines can offer against serious disease, including hospitalization and death. So I just want to state that again. And also for people who wonder about Omicron and, will we be needing an Omicron-specific vaccine? I'm wondering if you or one of the experts can talk about what's on the horizon with respect to the potential need or not. I don't believe it's clear that there will need to be an Omicron vaccine specifically developed, but I would love to hear from someone authoritative about where we're at with that. Thank you.
Thank you. Dr. Duchin, well, you know what I would like to do, if it's okay with everyone, Dr. Duchin, remind me that you asked that question, but what I would like for us to do is to maybe take a break, allow my CDC colleagues to confer about who the appropriate respondent might be to that. And I just want to thank the committee for an efficient day, an efficient vote, perhaps because for all of us, this decision was one that was straightforward and not complicated, unlike many of our other prior decisions. So appreciative that we have gotten through the morning, would like to actually take a 15-minute break. So let's plan to convene again at actually 25 minutes after the hour. We'll return for the afternoon session, which will be a focus on some of the clinical considerations and clinical discussions that have been ongoing. And Dr. Duchin, hopefully we'll be able to get back to your question then. Thanks, everyone.